up is Dr. Nainesh Parikh. Thank you.
Hi, good afternoon. Thank you for having me. I'm Nainesh Parikh. I'm an interventional radiologist here at Moffitt. Been here for about 7 years, and today I just want to do a quick overview of the interventional radiologist perspective in the management of gastric cancer patients. Really, it's an introduction to what interventional radiology is for our patients, because oftentimes it's an area of the hospital, and it's a specialty that patients don't know much about. So what is interventional radiology, or IR? It's a hybrid between surgery and radiology. We use images to guide minimally invasive surgery. It doesn't mean we do the same surgeries as our surgeons. It means we do different surgeries and we do them using images to guide us. It also means that we do things in a very, very, very minimally invasive fashion, which is very different. No major incisions, not in the operating room. Again, we collaborate and work very closely with our surgical colleagues, but we do not operate in the operating room. And we rarely admit patients either after or before our surgeries. We do participate in the care of patients who are admitted after their surgery very often. We rarely use general anesthesia. Oftentimes the things that we do are done with moderate sedation, which is something I'll explain in a few minutes. It can be viewed as less expensive compared to traditional surgery, but when I say less expensive, what I really mean is we are people who try to help around the edges oftentimes. So if there's a minor procedure that's needed, if there's help with our surgical colleagues that's needed, we are often called on for that. We work with other medical doctors, surgeons, and radiation oncologists and other specialties. And I know that can get confusing. Oftentimes people wonder, well, what's the difference between interventional radiology and radiation oncology? Interventional radiology, which is what I am, we use images to do minimally invasive surgeries. Radiation oncologists actually use radiation to treat cancer. So it's actually a very big difference. I think if we could go back, we'd probably change those names to be a little bit more different, but we are where we are with them. This is an example of the type of setup that you might find in IR. There will be an operating room table, and there will be some form of imaging equipment. This over here is what we call an image intensifier. It's actually radiation comes out of here, x-rays come out of here, and they get sensed by this piece of equipment. And the patient who lays on this table, when this is in the table, the x-rays come through the patient, they get sensed here, and they produce an image. And that is how we do our surgery. And this is a CT scanner that we also sometimes use. So it's kind of like an operating room environment. If a patient were to come into our environment, people would still be in masks, people would still have scrub caps on and things like that. But the difference is you wouldn't be expected to be put to sleep by an anesthesiologist. And it may not be the same location where all the other operating rooms are. This is an example in real time of what you can see. So again, here's this image intensifier. Sorry, it's a little bit blurry. X-rays are coming through the patient up to here, and then they produce images on the screen that we look at right here. You can imagine that whether we put needles into the liver or into the blood vessels, we use those needles to guide therapy, okay? So what is moderate sedation? Why do I bring that up? Well, patients, when they come to our department, often ask, are we going to be, we thought we would be asleep because this is surgery. And actually, when you're doing an invasive surgery, you do want to be asleep so you don't feel anything. But the fact that we don't make large incisions and the fact that we do things with needles means that typically the local anesthetic, just like you give or you get at a dentist, should work. So when we say that you will be sleepy or that you're receiving moderate sedation, what we mean is you'll be arousable, you'll be breathing on your own. And that's actually very important because the body's the best at breathing, actually better than our machines and better, even though my anesthesia colleagues are great, the body does the best job. So if you can breathe on your own, you should. And you'll be in a dreamy state. You may go in and out of consciousness. You may sleep. You may fall asleep. A lot of my patients end up snoring and they don't even know they're asleep, which is fine. That's exactly what we want. It's achieved by using a combination of medications, specifically Versed and fentanyl. And I say this is important because the combination of both of them produces a dreamy state called moderate sedation. And one alone doesn't really produce that effect. But when you combine them in little aliquots, actually it has a synergistic effect on the body. It's not only very potent, but it's actually very short acting. So once you stop giving it, and they give them every 5 minutes, either typically it's our nurses who give it under the interventional radiologist direction. Once you give them, they act very quickly, and then they actually get processed very quickly. So the body can spit out the byproducts and you can wake up very quickly. But that's why we give these every 5 minutes. And we also keep an eye on keep an eye on vital signs. Again, it doesn't need or require an anesthesiologist. Certainly an anesthesiologist can do moderate sedation, but it's actually not very complex. It's pretty simple. When you use little tiny aliquots of these two medications, all you have to do is give a little bit, make sure that you're monitoring the patient appropriately, and everything goes well. And I'd say about 95 to 98% of our procedures, we use moderate sedation. It is actually oftentimes compared to a colonoscopy so that patients understand exactly what the level of sleepiness is. It's actually less sedation than a colonoscopy. So for a colonoscopy, oftentimes you'll be out completely. With moderate sedation, you'll be out, but not entirely out. What are some common types of IR surgeries that you'll encounter as a gastric cancer patient? Well, the most common probably is something called a port placement. A port is something that accesses the central veins so that you can receive medications, you can have blood draw, you can receive contrast for imaging scans. But the point is, it's an easy way to access the blood. And one of the main ways you want to access the blood is for chemotherapy. And when you give chemotherapy, because some of the chemotherapeutic agents can be so toxic, you want them to go directly into a large blood vessel so that they don't burn up veins, they don't cause pain, they don't cause burning or any symptoms. The way we do this, again, is we do this in one of our IR procedure rooms. We use moderate sedation. It takes about 25 to 30 minutes. We make a little tiny incision to put the port in underneath the skin right here, and we tunnel it up over your collarbone, and we tunnel a catheter down into the blood vessel. And it sits there all underneath the skin because the skin is actually the best protectant against infection. So if you bury everything underneath the skin, it's the best opportunity to have something protected against getting infected. The whole procedure, again, takes 25 to 30 minutes, and then we do 30 minutes of before and after. And then this is just an example of how the port might actually be accessed. So a nurse or anybody else can actually feel the port underneath the skin. There are some markers. They can pin the port down, and then you use a tiny little needle. Actually, the chest is much less sensitive than your arms. So we find that patients tolerate this with a needle placement much more easily than in the arms. Little tiny needle goes in, you actually aspirate, and then you make sure that you have access to the blood, and then that's it. And then you can hook up for infusions, you can hook up for chemotherapy, you can hook up for contrast, you can also aspirate to get blood draws. And this way you don't always have to start an IV whenever you come to our center. So oftentimes, and I've heard Dr. Mehta say this to a lot of our patients, one of the standard things when patients get diagnosed with gastric cancer is to get a port, and they get it in IR. What's another procedure that we do commonly for gastric cancer patients? Something called a PleurX. A PleurX is actually the brand name of this. We call it a PleurX just because it is something that everybody knows. But essentially, if there's fluid buildup around the actual stomach or in the abdomen, rather than having to poke a needle through the skin and in there to aspirate all the fluid, we'll just leave a tube in. And the reason this is important is because it allows patients to have control of when they drain. So if patients have fluid buildup in their abdomen or in their belly and they get uncomfortable, they can just hook up with these bottles at home. A lot of home health services know how to operate these things, and you can actually buy these bottles even off Amazon. But this allows patients the ability to just drain at home and feel far more comfortable. And so the procedure itself, again, it takes about 15 minutes. There's a little bit of pre and post-op, but it's pretty quick. And we leave these in so that patients can feel comfortable and drain any fluid buildup on their own. Another type of procedure we do in IR, we do things called CT guided biopsies. So CT, as we all know, is a type of scan. It stands for computed tomography. The point is that it takes three-dimensional images of the patient, and then you see them on a screen in a two-dimensional fashion. It's important for us because your doctors may want to diagnose whether cancer has spread to organs such as the liver, the lung, the lymph node, the bones. And it may be a way for us in a minimally invasive fashion to get diagnostic information, not just to know if the cancer has spread, but to know things like molecular markers so that our colleagues can figure out which therapy to give you. Oftentimes, this is done, again, in the IR department. We do it. Most of these procedures take 15 or 20 minutes. They're, again, done with moderate sedation. But the point is that they're powerful procedures that allow you to guide your therapy. So don't be surprised if your doctors will refer for this kind of procedure as well in IR. Last thing I'll go over in IR is feeding tubes. I know we talked about it, my nutrition colleague talked about it earlier. This is something we do often for our patients. So patients, maybe they need nutrition, undergoing active chemotherapy, maybe they've had surgery, all depends. Both my colleagues up here in the front have referred for feeding tubes in various different scenarios. The point is to allow a tube to be in place so that the patient can receive supplementation through the alimentary tract. Obviously, that's the best way, if at all possible, to mimic how we eat normally anyways. These procedures, again, take place in IR. They take place with moderate sedation. There's various levels of sedation that are required to have either of these procedures done. But the point is, if we put a tube in IR, it allows for easy access to the alimentary tract for patients. We don't necessarily, we rely on our dietary colleagues to know exactly what the supplements are and what's supposed to be placed through the tube. So I'll acknowledge that I definitely do not have a specialty in that area. But we try to be a part of the entire multidisciplinary team so that things like this can be inserted for you depending on what you need. They do have to be replaced every 6 months, and we are the people who manage issues that arise with the tubes. Remember, these are things like engine parts, unfortunately. So they don't work as well as the body does. They can leak, they can get clogged, all sorts of things can happen with them. Just know that IR is there to help manage all these things. So what are the reasons you might be referred? Well, any of these minor procedures, port placements, G tubes, J tubes, biopsies, things like that. And then we do more involved services, especially when cancer does spread to the liver, probably beyond the scope of the discussion for today. But typically it's your medical oncologist or your surgeon who would refer to our department for help. I think that's it. Any questions? All right, well, thank you for having me.